Very good morning to each one of you. I am extremely honored to be a part of this Medalist study go, and it's been a pleasure to have all of you here on a Sunday morning. And I promise that by the end of today's presentation, you will have a better understanding of this subject. So, at any point, if you feel you have any doubts, you can put your questions on the chat box. If it is relevant, I'll try taking the questions as we go. If not, we'll try to take the questions at the end. And if there's if you cannot hear me, if you cannot see the video's presentation, just interrupt me. I want you to make the most out of today. Okay. So without further ado, yes. So now I believe the biggest problem we all are here is because all our lives or all our BDS lives, we've always wanted to escape perio. And I guess this is true for almost everybody. Now, the reason why we've escaped could be one of the two things. Understood perio, it was all imaginative, all theoretical, and we never really could picturize the procedures, and that's why we never really developed that interest. Or the other reason could be when we've started our practice, we've performed certain soft tissue procedures and we failed miserably. And this has disheartened us. So it's possible that we've escaped or we've been escaping perio. Now, the bigger problem is it's okay. We think it's okay to escape perio, but perio does not escape us. So, if you're a student, I believe we have a mixed crowd over here. I believe we have some PDS students and some MDS students as well. And we also have some going to have to give an exam. So you need to know a thing or two about perio. But say you clear the exam, you pass out. When you get into practice and if you decide that you're never ever going to have anything to do with the periodontium henceforth, you're wrong. When you start practicing, no matter what teeth, if you do not know a thing or two about the gums are going to come in the way and it is going to ruin your entire treatment. So if you don't pay attention to perio is going to make you pay attention to it at some point in your lifetimes. Now, since we already know that all of you are trapped, all of us, we are trapped in this forever, might as well use this time to understand perio and to like even if you don't go ahead and do the procedures ourselves, at least we should have good knowledge of the subject, and that is why we are here. Now, let me tell you today's presentation. It's not a theory lecture. I'm not taking a theory lecture required about each type of procedure here in the presentation. The intention of today's presentation is for you to understand the concepts, because I believe that in periodontology, like I see my students, I see a lot of practitioners out there who is through the use of certain hand sketches that some doodles that I've made, and certain videos. I'm going to try to clear your concepts about flap surgeries in perio. And at any point, if you have any doubt, please stop me, interrupt me, and let's clear your doubts before we go ahead. Okay? So the surgeries that we are going to be looking at today are the textbook surgeries, that you will come across in your textbooks. So we will be looking at gingivectomy, gingivoplasty, conventional flap, modified Widman flap, undisplaced flap, apically displaced flap, papilla preservation flap, and the distal wedge. For the BDS students to understand. So it's going to be a very, I'm going to take you all down to the basics, but I'll try to also give you information that will help you in your clinical practices so that we can balance the knowledge sharing for the entire audience. So we have a completely mixed crowd, and I'm going to try to make sure that this present, please do make sure that you learn by the end of today's presentation. Okay, so before we move on to the actual procedures, let's delve into the incisions in perio. Now we learn about a lot of incisions, but what incision is given how and what is the use of a particular incision? We are going to dissect all of that today. Perio can grossly be divided into horizontal and vertical. When I say horizontal, I'm talking about the occlusal plane. Any incision that is along the occlusal plane becomes horizontal, and any incision that is perpendicular to the occlusal plane becomes vertical. For example, uh, this is how horizontal incisions look like. Okay, so in this image, you can see that the incision has been given along the necks of the teeth. So that is a horizontal incision. Vertical incisions are incisions that extend from a horizontal incision down apically towards the mucogingival junction. Okay, now the role of a vertical incision is to help in better access of the underlying tissues. A horizontal incision is going to just open the gingiva like a pouch. A vertical incision is going to help in better access, better viewing of the underlying tissues. But we don't need this in every case. Just understand that you don't need to access the deeper structures or view the deeper structures in every case. That is why most commonly we do not use vertical incisions. We most commonly give only a horizontal incision. But in certain cases, suppose say a case like sinus lift, or if you're trying to graft bone graft and are trying to access the bone deeper, then you might have to give a vertical incision. Now, there are two types of vertical incisions. You can have a single vertical incision. If that is enough to give you accessibility, visibility, one incision is enough, or you may have to give two incisions. Now, the benefit of giving two incisions would better, more visibility than a single vertical incision. At the same time, it mobilizes the flap. The flap that you've reflected is now completely movable. So you can shift the flap apically, coronally, laterally in any direction and you can suture it. So when you want to do a displaced flap, so what is a displaced flap? Once you reflect original position, that becomes a displaced flap. So a displaced flap could be apically displaced, coronally displaced, or laterally displaced. When you want to do such a flap, you're going to have to give vertical incision so that the tissue becomes very movable and mobile. Okay, so vertical incisions improve accessibility, visibility, and also make the flap more mobile and movable. But the disadvantage of giving vertical incisions is you're going to compromise the blood supply of the flap because you're cutting off the blood supply. In a horizontal incision, see in this image over here, in a horizontal incision, the entire base of the gingiva, entire gingiva gives blood supply to this area. So the healing is almost, it's very good. But if you give a vertical incision, you're going to cut off the blood supply from the remainder of the gingiva. And when you give two vertical incisions, the blood supply is going to be compromised even more. That is why we are very careful and very stingy when we decide to give vertical incisions. Only if it is absolutely necessary, you plan to go ahead and give vertical incisions. Okay. Okay. Now, based upon the design, now in horizontal, we have two types again. You may have a scalloped incision where you of course, like you can see the necks of the teeth. This scallop can be around the necks of the teeth, like you can see over here, or it can be away from the gingival margin. I'll be showing you pictures ahead. Okay, it can be away from the gingival margin. The other type of incision that you can have is a straight incision. I'll also tell you where the straight incision is used, especially if you want to reflect the buccal flap and you don't feel it, you can give a straight incision and just reflect the buccal flap. This is done in a papilla sparing flap. I'll be showing you all the types of flaps ahead. Okay. Okay. Now, that was based on the orientation to the occlusal plane. Now, based upon the okay, you can see this gingival margin, the left side of the image. So, based upon the blade orientation of the blade with respect to the gingival margin, the blade could be inserted inside the gingival sulcus, like you can see in this image. Okay, inside the gingival sulcus, facing downwards apically. This is called crevicular or sulcular. Okay, crevicular because it goes in the gingival crevice. The crevice is also called as sulcus, so sulcular. It is also called as intercrevicular, intracrevicular, intersulcular, intrasulcular. Okay, just different names. Now you can observe that when you place your incisions in this manner and you excise the incise the tissues, all of this uh, gingiva is going to come on your buccal flap. Okay, when you reflect the flap, the entire tissue is going to come on your buccal flap. So that means you're preserving the entire gingiva. Now you're going to place this kind of incision in areas where you need to preserve the entire gingiva, say anterior region. In the anterior teeth, you do not want to sacrifice any gingiva because it is going to cause an anesthetic display of the roots. So in those cases, you want to preserve the entire gingiva. Or in cases, say where you've done bone grafting, regenerative procedures, you want the bone graft to be covered by good amount of gingiva. So in that case, in these cases, you're going to want the gingiva to cover it completely. You do not want to sacrifice any gingiva at all. Okay. So this incision is preferred in aesthetic areas and also in areas where you're going to go for regenerative surgeries. Okay, now another orientation of the blade, another way could be on the tip of the gingival margin. This is called crestal or splitting the marginal gingiva into two. Okay, I'm splitting the marginal gingiva into two. The gingiva that is present inside, that is towards the tooth surface of the incision, is going to get sacrificed. I'm going to have to throw it away. Okay, and the gingiva that is present on the buccal surface is going to be preserved. So you will get an idea looking at this image that the gingival margin, half of it is preserved and half of it is thrown away. So you can only do this in cases where you have thick gingiva. Okay, so if a patient has a thick gingival biotype, or sometimes when patients have too thick gingivas where you want to thin it out, where you need to thin it out, you're not in by giving this incision, you're splitting the thickness of the gingival margin into two, but you're not reducing the height at all. The height of the gingiva remains the same. Okay, the third type of incision is a submarginal incision. A submarginal incision is an incision that starts at a point below the gingival tip of the gingival margin, anywhere below that. It could be at any level. That becomes submarginal incision. Now, in this type of incision, you are not only getting rid of this tissue that is inside. Okay, all of this tissue, you're going to sacrifice that tissue, not only the thickness, but the height of the gingiva as well. So by giving this incision, we are not only reducing the thickness of the gingiva, we are also losing some good keratinized tissue. But in some cases, you have a lot of keratinized tissue, and there you don't mind losing a little bit. So that is, if you don't have enough keratinized tissue, you never go for this procedure, this third incision. Or say in the anterior teeth, or when you want to place bone grafts, you never give this third incision because you do not want to compromise the aesthetics. You do not want to compromise the graft integrity. Okay, so these are three types of faced apically. Okay, all of these incisions are faced apically. Originally, the third incision that I showed you, the submarginal incision, used to be called the internal bevel incision. Because when I say internal bevel, what bevel am I talking about? I'm talking about the bevel of the blade. When the bevel of the blade faces towards the roots of the teeth, it is called internal bevel. Okay, so in an internal bevel incision, the third incision used to be called the internal bevel incision, but now all three are come under the internal bevel category, because when you say internal bevel now, it could mean any either of these three. Okay, yeah. Now, the incisions that we saw now were all internally oriented. Now let's see based upon the direction of the blade, you have two types of incisions again. Internal bevel that we just saw, and the other one is is an incision in which the blade is directed, the bevel of the blade is directed towards the crowns of the teeth. Okay, the bevel of the blade is directed towards the crowns of the teeth. So this is called the external bevel incision. So when the tip of the blade faces the crown, it is called external. Okay. Now, in historically, there was flap surgery came after gingivectomy. Initially, there was only gingivectomy. So whenever there were perio problems, periodontal disease, only gingivectomy used to be performed. That is why the first incision that came was the external bevel incision, and that is why if I say bevel, I mean external bevel. It wouldn't mean internal bevel. The original bevel is the external bevel. Then when flaps came later, they reversed the direction of the bevel, and that is why this internal bevel incision is called the inverse bevel or the reverse bevel, because it is the opposite of the external bevel. Okay. Now, if you can appreciate in this image that when I give an external bevel incision, I do not touch the bone. But when I give an internal bevel incision, I am going to hit the bone. So the objectives of both these procedures are different. We'll study that ahead. Now, since both of these incisions start apical to the gingival margin, tip of the gingival margin, both of them can be called submarginal incisions. We saw clavicular or sulcular, we saw crestal or also called as marginal, and we saw submarginal. So the submarginal incisions are incisions that start below the gingival margin, and it could be directed apically. In that case, it is called internal. It could be directed coronally. In that case, it is called external bevel. Okay. Okay. Now, I hope you've understood the incisions. If you have any doubts, please drop it on the group. Shivani has mentioned she couldn't hear something, but which part could you not hear? So now, when we saw the different types of incisions, we are going to see when to do what, depending upon the source of the problem. Now, let's say when you come to perio, like you learn about gingival diseases, periodontal diseases, etc. Let's simplify it for you. We should identify what is the source of the problem. If the source of the problem could be gingival, okay, it could be gingival inflammation. The gingiva could be either inflamed, it could be overgrown, that there could be an abscess or any problem. But the problem in this case, on the right side of the image, is only gingival. You only have a problem with the gums. The problem could be gingiva and bone. Like on the left side, you could have a little bit of gingival inflammation and bone resorption as well. Or the problem could be only bone. So the bone has resorbed, but the gingiva is healthy. Okay, so there are three scenarios. First scenario is where only gingiva is the problem. Second scenario where gingiva and bone both are the problem. And third, where only bone is the problem. There's resorption, but there is no inflammation in the gingiva. Okay, so based upon the source of the problem, our surgery is going to be gingival. Say it is gingival inflammation, you don't go for a surgery in case of inflammation. You do a good phase 1 to get rid of the inflammation. But apart from that, whatever remains, so if you have a gingival overgrowth or an abscess or pseudo pockets are pockets where pockets because of gingival overgrowth. Okay, there's no problem in the bone, like you can see in this image over here. If the problem is not need to expose the bone at all, right? In this case, the incision that you're going to be using is the external bevel incision. Okay, because here the problem is only the overgrown gingiva. To get rid of that little bit of overgrown gingiva, you need to give an external bevel incision by which this part of the tissue is going to get sacrificed. Okay, the overgrown part is going to go away. So this procedure is called gingivectomy. Okay, gingivectomy is excision of the gingiva or resection of the gingiva. In gingivectomy, we get rid of the pocket depth. So for your dimension, so the vertical dimension height of the gingiva is reduced, resected. And while doing that, we're also thinning the gingiva, giving the gingiva nice knife-edged margin. Okay. Now, if the height is not a problem, but it is the gingiva is just irregular. Okay. In that case, like in this image over here, you can see that the red dotted line is going to be my final gingival margin. So I'm just going to smoothen and shape that area. That procedure is called gingivoplasty, or you use contouring incisions here to contour around along the surface of the teeth, okay, and the bone. Okay, so gingivoplasty, for your understanding, is reduction of the gingiva in a horizontal dimension. But teeth settings, when you make a teeth setting, you first add a lot of wax, and then the first thing you do is you cut the wax grossly to reduce the height, the thickness of the wax and the height of the wax. And then once everything is done, then you take your wax knife or a wax spatula and you smoothen the gingiva. So the first thing is equal to gingivectomy and the second step is equal to gingivoplasty. Okay, so yeah, so if the problem is with the gingiva, it would either be gingivectomy or gingivoplasty. Okay, now let's say the problem is with the bone. Like in this, the left side of the image, you can see that there is bone resorption. There is bone resorption, the gingiva has dipped in and you have a nice big pocket over here. So if the problem is with the bone, you need to expose the bone, right? Because if the problem is with the bone, you might have to either expose the bone and do resective osseous surgery or a regenerative osseous surgery. You might have to do something to the bone. So whenever you want to expose the bone, your incision should always be facing down. And then only you're going to expose the bone when your blade hits the bone and you reflect the flap. So if the problem is with the bone, you need to raise a periodontal flap. Okay. And here I've shown the crestal incision, but it could be any. It could be sulcular, it could be crestal, it could. Okay, I hope this is clear for you all so far. Okay. Now, the goals of periodontal surgeries. Now, why do we do periodontal surgeries? The primary goal, and you can remember it in this way, the primary goal of periodontal surgery is to access deeper structures. We only do a surgery because we want to access the deeper structures, to do either to clean or to resect or to regenerate, to do anything, but sometimes only to observe. But you need, in order for you to access the deeper structures, you're going to go for periodontal surgeries. And the primary goal is not pocket reduction. A lot of times it is just to access the deeper structures because there is lots of calculus built in the subgingival area. When you raise a flap and you clean everything out, you scale it out, you do good debridement and you suture your flaps back again, the pocket automatically gets reduced. So the primary aim is to access deeper structures. The secondary aim is for pocket reduction or elimination. Now, like I told you, historically, it was only gingivectomy. There was only gingivectomy, okay? And gingivectomy used to serve both these purposes. When you cut off the excess gingiva, you also get access to the deeper structures and you also reduce the pocket. So it's a good thing. It's a good procedure. But there were certain drawbacks for this procedure. Okay, that is why flap surgeries came into picture. Now let's see what were the drawbacks of doing gingivectomy. Like I showed you in the images, when you're doing gingivectomy, you're going to sacrifice tissue. You're going to sacrifice a chunk of tissue which you're just going to throw away. So you're going to sacrifice very valuable, it's gold, keratinized tissue. Now, a lot of patients don't have extra keratinized tissue. If you have loads of keratinized tissue, it's okay if you cut off and throw a little bit, doesn't matter at all. But if a patient already lacks keratinized tissue and in that you do a gingivectomy, then the patient is going to be left with little or no keratinized tissue. And why is keratinized tissue important? Because keratinized tissue makes it easy for a patient to perform oral hygiene procedures and to eat. If a patient does not have keratinized tissue, it becomes very difficult for them to keep that area clean. Brushing is very painful, and when you eat, the bolus keeps moving there in circles. So it is important for a patient to have keratinized tissue, and this procedure would sacrifice keratinized tissue. Another drawback of this procedure was if you had to do something to the bone, gingivectomy wouldn't give us access to the bone. Like I showed you, the incision just surpasses the bone. So it does not let us touch the bone. So you cannot regenerate, resect by doing gingivectomy. That is why flap surgeries came into picture to counteract these drawbacks of gingivectomy. Now, when you do flap surgeries, of course, we have different types of flap surgeries. You can preserve keratinized tissue. You can preserve completely if you give sulcular incisions. You can preserve a lot if you do the other incision. So obviously you can still preserve keratinized tissue, and it also allows us to raise a flap so that we can go ahead and resect or regenerate the bone. Okay. Now we are going to move on to one procedure, gingivectomy. I'm going to so the videos aren't playing here. So I'm just going to be opening the videos separately. So now we are going to do gingivectomy of this gingival overgrowth. So what you're going to do is, first of all, you're going to probe and see how much extra gingiva you have. In this case, it's almost 5 millimeters. So that means the sulcus depth here is 5 millimeters. So what you're going to do is, first of all, you're going to probe and see how much extra gingiva you have. In this case, it's almost 5 millimeters. So that means the sulcus depth here is 5 millimeters. Now, the ideal sulcus depth is 3 millimeters. That means you have 2 millimeters of excess gingiva here. So here you do not have to do osseous resection. You just have to reduce the gums, just the gingiva. Now, what you have to do here is, you're going to, the incision that you use in gingivectomy is an external bevel incision. Here, because there's a gingival overgrowth, you have to make sure the overgrowth is also excised in the same incision while reducing the height of this. So, this premolar, the clinical height of this premolar is also reduced. So, you can do gingivectomy to treat two things: to get rid of the excess gingival overgrowth and to increase the clinical crown height of teeth. So, let's move ahead. After anesthetizing, the incision that you're going to be using is external bevel. Now, when my blade faces apically, this becomes internal bevel. When it faces coronally, it becomes external bevel. So I'm going to be using an external bevel incision. Okay, so what I'm going to be doing is facing the blade coronally, 45-degree angle to the long axis of the tool, and then walking the blade to get rid of the gingival attachment. Okay, so this is how you do it. Now there are going to be places where it is attached. So you can hold it with your tissue forceps. Okay, and just wherever the tissue is attached,
Just release it with your blade. And this is how the gingival overgrowth has come out. Okay, this is how you perform gingivectomy. Now you have these excess tissue tags. You have to smoothen this out as well. Okay, so you can do it using two instruments. One is the scalpel, where you can just excise it like this. This is exactly how you do gingivoplasty as well. You're not reducing the height of the gums here, you're just reshaping the gums. So this becomes a step in gingivoplasty. Okay. And another way to do it is by using a castrovisual. So you can take your castrovisual scissor and you can excise the excess tissue tags. Okay, so these are two ways of removing the tissue tags. After that, you have to make sure that the gingival architecture is correct. If not, you can give that a little shape as well. Okay, again with an external bevel facing upwards. You can reshape the gingiva, recontour it. You can use a curette to remove all the excess tissue tags. Again, smoothen the gingiva wherever required. Always give this walking motion. You can never just cut like this. It never cuts like that. You have to give a sawing motion when you're doing gingivoplasty. This is called a sawing motion. And try not to face a blade towards the vestibule, because sometimes it can slip and it can hurt the patient really bad. So always have your blade facing upwards towards it. And that is how we perform gingivectomy and gingivoplasty.
So, you all now saw the procedure of gingivectomy and gingivoplasty, and you realized how, while doing that procedure, we excised some tissue, lost some keratinized tissue, but we also ended up thinning the tissues, giving it a nice shape. And you also must have realized that by doing that procedure, we have not reflected the flap, so we have not been able to access the bone, and that is why we're here with flap surgeries. Now, the most basic flap that we all must know is the conventional flap. Okay, conventional flap is also called an envelope flap. In the conventional flap, there's only one incision. Okay, this is the flap that most of us do all the time. So, the incision that is used in a conventional flap is a crevicular or a sulcular incision. So you take your blade, 15 number 15C, or some people like to use 12 as well. You take your blade and you incise the tissues from the depth of the gingival sulcus. So you insert your blade into the sulcus and you hit the bone. Once you do that, your flaps are going to reflect. Okay, like you remember that I told you earlier, when you give a crevicular or a sulcular incision, we preserve the entire soft tissue. So you reflect the entire soft tissue onto the flap. You curette, you degranulate, do the scaling, whatever has to be done, any resection or regeneration of the bone, whatever has to be done, you do all of that, and then you suture the flap back again. Okay, this is the simplest type of flap, which is called a conventional flap. Okay, a conventional flap can be used in most of the procedures. Now, let me show you the video of the conventional flap.
So for the conventional flap design or for an envelope flap, the incision we give is a crevicular or a sulcular incision in which the blade is inserted into the gingival sulcus and it is walked through the sulcus while hitting the bone. In this flap, there's only one incision. So it is called an envelope flap because there are no vertical incisions. Once the incision is done, you take a periosteal elevator, you insert it into the sulcus, touch the end of the periosteal elevator to the bone, and reflect. Then slide the periosteal elevator ahead and then reflect again. And slide it ahead and reflect again. And that is how you raise a flap in conventional flap.
Okay, so in a conventional flap, what we did was we placed only one incision and we reflected the entire flap like a pouch. Because we reflected it as like a pouch, we also call it an envelope flap. The next surgery we are going to be seeing is the modified Widman flap surgery. Now, this is the most complicated to understand. In modified Widman flap surgery, there are three incisions. Okay. Now, the first incision is the internal bevel incision or this a submarginal incision facing internally. Okay, so this is your first incision. When you place this incision, the second step you're going to do is you're going to reflect your flap. Okay, so after placing this incision, you're going to reflect your flap. So you can automatically see how this part of the tissue that is attached to the teeth remains attached to the teeth. So that is the part of the tissue we are going to sacrifice. Then to remove this part of the soft tissue, you need two more incisions. The second incision is the sulcular incision. Okay, that is the clavicular or the sulcular incision which enters through the gingival sulcus. And the third incision is the dental incision, which is at the level of the bone. Okay, by giving these two incisions, you're going to get rid of the collar of tissue. So the collar of to come out. Okay, so after removing the collar of tissue, this is what a flap looks like. And then you go ahead and do whatever you have to do to the bone and you go ahead and suture the flaps. Okay, so this becomes the modified Widman flap surgery. Now, when you do this surgery, number one, we get rid of some tissue by sacrificing some tissue. So you will not do this in anterior region. You will not do it in cases where you're doing bone grafting, but you can prefer to do this in the palatal region because the palatal mucosa is very thick. So sometimes you can do this on the palatal side. Aesthetics is not of a concern and you're going to end up making the flap nice and thin and knife edged. Okay, so you can prefer it to do it in the on the palatal surfaces, or you can also do it on the buccal surfaces of posterior teeth if the gingiva is thick. Okay, and you don't mind creating some recession. If that is okay, then you go ahead with this type of flap surgery. I'm going to show you a video of that now.
In the modified Widman flap surgery, there are three incisions. The first incision is called the internal bevel incision, and it starts at 0.5 to 1 millimeter apical to the gingival margin, so roughly over here. You start from one of the line angles and you proceed mesily. Make sure to hit the bone. When you approach the papillae, spare the papillae. Don't include it in your flap. And then start again on the next tooth. After the first incision is placed, you take your periosteal elevator and you start reflecting the flap. Support the flap with your non-working hand. When you reflect the flap, you will have a collar of tissue around the necks of the teeth, which will then be removed by the second and the third incisions. The second incision is a clavicular incision, similar to the incision given in an envelope flap. Pass the blade through the gingival sulcus. And by doing this, you're going to separate that collar of tissue from the underlying bone. The third incision is an interdental incision in which the blade is kept horizontal to the long axis of the teeth, and the base of the papillae or the base of the tissues at in the interdental area is relieved of the tissues. Then you take the curette and you just curette the tissue out. It may come out in the form of a collar.
Okay, so in the Widman flap surgery, we gave 3 incisions. The internal bevel incision also has the first incision. The clavicular incision or the sulcular incision also got second incision, and the interdental incision. By giving these 3, we've sacrificed tissue. Okay. Now let's move on to the next type of flap surgery, which is called the undisplaced flap. Now, the undisplaced flap is also called as internal bevel gingivectomy.
Dr.
This
Sucheta, I think
flap is very...
Shivani has a question for you. If you could see the chat box, Shivani has mentioned that she wants to know the clinical indications of modified Widman flap. So if you could explain that a bit.
Okay, I just saw the questions. Okay. Could you please elaborate on the clinical indications? So, clinically, you will go for a modified Widman flap surgery if the gingival margin of your patient is thick. If it is thick enough and you want to thin it out. Okay, you want to thin it out, and at the same time, you want to raise a flap because the patient needs a flap surgery. Okay, why do we do flap surgery? To debride if there's calculus, to remove all of that, or to do any bone procedures. So if the patient needs a flap surgery and the tissues are thick, you go for modified Widman flap surgery, and you prefer to do this in the posterior regions and the palatal surfaces. So most of the flaps, you can go for a conventional flap on the buccal surface and a modified Widman on the palatal, because palatal is almost always thick. Okay, palatal is almost always thick. So going for modified Widman thins that tissue out as well, and it makes it nicely adaptable. Once you thin out the tissue, it adapts very nicely to the bone. So basically, in these cases, you do it. Where do you not do it? More than where you do it, try ruling out where not to do it. Aesthetic areas of aesthetic concern, and wherever you're going for regenerative surgeries, you do not do it. Okay. Okay, thank you. So there's one more question. Can you show internal bevel incision is done on the cast? What I'll do is I'll just play another video to show the internal bevel incision before I move on to this flap. Because it's seen better in that video. So this is a video of crown lengthening actually, but then I'm just going to show internal bevel incision on this.
External bevel incision. Since we want to touch the bone, you give an internal bevel incision, not an external. You connect your bleeding points, but you have to make sure you do not excise the papilla. So never cut the papilla. Cut around the papilla. Preserve the papilla, and then just go ahead and connect the bleeding points. Okay, so this is an internal bevel incision. So you can see how I've spared the papilla here. I've not incised the papilla at all. You can redefine your incision to make sure you hit the bone properly. Okay. You do the same thing on the adjacent tooth. Preserve the papilla. Don't cut the papilla. Okay. Now this incision has separated this piece of tissue, but this collar of tissue will only come out when I give the second incision. that is the sulcular or the clavicular incision. So you do this and you hit the bone. You have to make sure you hit the bone. You can see how I've been walking the scalpel, the blade, and not running it to hit the bone. When your incision is good enough, the collar of tissue should come out easily like this. Okay. Now, in the around the molar, it's probably attached somewhere, and that is why it hasn't come out. So now, once you separate that, the collar of tissue comes out. Okay.
I hope that answered your question. Okay, so I have a question. Does CLP always need internal bevel? Not necessary. If you want to do a crown lengthening procedure where you're going to reduce the bone as well, you 100% need internal bevel. But if you want to just increase the height of the crown and only gingiva is the problem, you can just excise it by doing a gingivectomy also. So crown lengthening is done by two procedures, gingivectomy and internal bevel with osseous reduction. So the blade that I use is 15. So usually it's 15 or 12 that a lot of people use. I use a blade called 15C, which is a smaller version of the 15 number blade. What I'll do is I'll just show you the instruments at the end. Like I'll just do that. Okay. What we'll do is we'll finish this and then we'll take questions if that is okay. So I'll be able to address all these questions together. Okay, so now the undisplaced flap. Now the undisplaced flap, like I told you, is also called as internal bevel gingivectomy. Now the steps are similar to modified Widman flap surgery. Okay, get this in your heads. The steps of an undisplaced flap are similar to modified Widman flap surgery. The indication is different. Okay, now in this case, you can see that there's a gingival overgrowth. If or there's a big gingival pocket over there, a periodontal gingival pocket, that means a pseudo pocket. So if you want to get rid of this growth, but you want to raise a flap at the same time, there is a solution which is called the undisplaced flap. So there are two ways of treating this enlargement. I could either do a plain simple gingivectomy like I showed you before, an external bevel gingivectomy, by which I can get rid of that extra part of tissue and I'll be done. But if I want to raise a flap at the same time, like you can see there's a little bit of bone loss here. If I want to do something to the bone or for any reason I need to raise a flap, I can go for flap surgery that is similar to an internal to a modified Widman flap. So the first incision is going to be internal bevel incision or a submargin. But the starting point of this incision is going to be different. The starting point of the modified Widman flap surgery ka incision was 0.5 to 1 millimeter away from the tip of the gingival margin. In modified Widman flap surgery, the internal bevel incision started 0.5 to 1 millimeter apical to the gingival margin. In undisplaced flap, it is going to be different. So what you do is you take a probe and you measure the depth of the sulcus. Okay, you measure the depth of the sulcus. Whatever is depth, say it is 6 millimeter. You start your incision 3 millimeters from the gingival margin. That is basically half of it. Like see over here. The entry point of my blade into the gingival into the gingiva is midway between the height of the distance between the gingival margin and the alveolar crest. Okay, so you take a probe and you pierce the probe till it hits the crest of the bone till here. Okay, that is called bone sounding or transgingival probing. So you measure that distance and you take half of that and you enter from there. Okay, by doing this, I'm not only going to eliminate the excess gingiva, but I'm also going to cause thin margins, create thin margins. Again, the second incision was the clavicular incision. The third incision was the interdental incision. And by doing that, we have gotten rid of the excess tissue and we have created nice thin gingival margins. This is called an undisplaced flap. So undisplaced flap is similar to modified Widman flap surgery. It is the indications are different. It is done when you have gingival overgrowth and you want to do something to the bone, or there are pockets. There is true and false pockets at the same time. Okay. And the entry point of the first incision is different. That's the only difference between these two procedures. Okay. Now, apically displaced flap surgery. In apically displaced flap surgery, like the name suggests, you're going to raise the flap and shift it apically and you're going to suture it. But why do we do this? Like in this diagram, you can see that the gingiva does not attach to the bone. It just goes mid-air, it is going like that. So that means a part of this gingiva is attached, whereas a part is unattached. Okay, so this is a little bit of attached part, and then this entire region that has gone down, the entire gingiva that has gone down like that is unattached. So this procedure is going to help us create attached gingiva. Okay, apically displaced flap is going to help us create attached gingiva. Also, the amount of soft tissue above the bone is good enough. You have nice height of soft tissue. So you're going to reflect that and you're going to pull it down. So at the same time, you're going to eliminate the pocket as well, because the entire pocket lining is going to get lifted and sit on the bone. Once I show you the diagrams, you'll learn better. Okay. And the third thing you're going to achieve by this doing this procedure is you're going to also increase the height of the tooth, clinical height of the tooth. So this procedure is going to help you achieve three things: increase the width of the keratinized tissue, reduce or eliminate the pocket, and also increase the clinical height of the tooth. So it has three advantages. Now what you do is, in this image, you can see that the gingiva on the right side is thin, whereas that on the left side is thick. So there are two ways to do an apically displaced flap surgery. If you have thin gingiva, the incision is going to be different. If you have thick gingiva, the incision is going to be different. Let's see the thin gingiva first. If you have thin gingiva, you want to preserve everything, right? That's what we learned earlier. So if you want to preserve everything, you give the clavicular or the sulcular incision. By giving this incision, you're going to have all the tissue on the buccal flap and you're going to save it. Now, if you have thick gingiva, you can give a crestal or a marginal incision. By doing this, you're going to split the gingiva into two, the gingival margin into two. And you're going to continue it down as a split thickness flap. That means what is a split thickness flap? A split thickness flap is a flap in which a part of the flap remains on the bone, that is connective tissue. A part of the connective tissue of the flap remains on the bone, and some connective tissue along with the epithelium is raised in the flap. Okay, so if you have thick gingiva and you want to do an apically displaced flap, you can do a split thickness flap, like follow the lines that I've shown in the image, and you can raise a split thickness flap. Now, when I raise both these flaps, it's going to look like this. Right side where there was thin gingiva, entire gingiva is there in the flap. Left side where there was thick gingiva and I split it, the part of the gingiva that is on the tooth is the one that I've saved. I'm not going to remove that. I'm going to save it. So that it's split into two parts basically. Okay, now apically displaced. Now you reflect the flaps all the way to the mucogingival junction so that it becomes nicely mobile. You may have to give a vertical incision or two vertical incisions, preferably two vertical incisions in this case, because you want to displace it apically. And then you shift the entire flap apically and you suture it. Okay, like you can see in this diagram over here. The right side, I've displaced the flap apically and I've sutured it. Okay, the left side, have done the same, but a little bit of the previous tissue is present on the surface of the tooth. Okay, so the way you suture both these flaps are different. That's a little too complex probably for this lecture, but the way you suture both those flaps are going to be different. So this is how an apically displaced flap is done. Okay. I'll try to show you. I don't have a good video of this procedure because it's difficult to demonstrate on the model, but I'll try to show you a YouTube video which will do justice to your understanding of this surgery. Show you that, and then this is an animal model. So here you can see that vertical incisions are given. That is how a vertical incision is given at 9 angles of the teeth. So you can see how vertical incisions are given. That is how vertical incisions are given. And then this is an internal bevel incision or a sulcular, depends on whether you want to thin the tissues or not. This is how a split thickness flap is raised. Okay, so you can see that a part of the connective tissue is on the bone. Now, this is a pig jaw, and on a pig jaw, the mucosa is very thick, so it looks very easy here. But in patients, especially in Indian patients, you have pretty thin gingiva, and it becomes a little challenge. It's pretty challenging to perform this procedure, very technique sensitive. Once the flap is shifted apically, it is sutured at that position. So you have these holding sutures where you suture the flap to the periosteum that you've left on the tissues, on the bone. And now you can see that the tissue over there has bunched up, but it only stays like that for a while. When it heals, when that tissue heals, that bunched up tissue merges with the rest of the tissue. And the good thing is, the beauty of this procedure is when it heals, the movable mucosa converts into attached mucosa. So when you can see in this first diagram over here, there was a little attached gingiva. In the second one, it's completely formed. So the entire thing attaches to the bone and it becomes keratinized. So it becomes attached gingiva. So you're going to help in the creation of attached gingiva by doing this procedure. Okay, now let's move on to papilla preservation flap. A papilla preservation flap is a flap in which you want to preserve the papilla. So there are two ways to do this. Now it is obviously done in the anterior regions, or it can also be done when you use bone grafts. I'll tell you why. So the original papilla preservation flap, you take, instead of taking the incision on the crest of the bone, okay, instead of placing the incision on the crest of the bone or mid-crestally, you take the incision palatally. Okay, palatally, and then you reflect the entire flap. The papilla comes on the buccal flap completely. So you're going to basically what we did here is we did not split the papilla. Now, why is it important to save the papilla? Out of the entire, you must have studied attached gingiva and gingival margin in different parts of gingiva, but the most important part of this of the gingiva is the papilla. First of all, it's difficult to clean interdentally. So plaque gets accumulated over there and it's difficult to clean that area. The first part of the gingiva that gets affected is the papilla. Also, the papilla has end arteries. If you must have studied it, end arteries are basically, it has an artery, an arteriole which stops at one point. There is no collateral circulation. In collateral circulation, you have multiple small arterioles supplying that area. So if one gets blocked, there's this blood supply coming from other areas. The gingival margin has collateral circulation, but the papillae do not have. So because the papillae have end arteries, only one artery that supplies the papilla, and if it's blocked, the papilla gets necrosed. That is why we have diseases such as acute necrotizing ulcerative gingivitis. That is why it is very crucial to save the papilla. And also it looks very anesthetic. in the anterior region, it's going to be called as black triangles. And in the posterior region, it also helps food accumulation. So that is why we do not want to lose the papilla. So whenever you raise a flap, you reflect a flap. If you split the papilla in half and reflect it, when it heals, it shrinks. It always shrinks. And that is why we want to eliminate that, and that's why you do the papilla preservation flap. Okay, now in this flap, once you raise the flap, you do whatever you have to do to the bone and you place it back in suture. So the suture is going to be on the palatal surface. Okay, so this is called the papilla preservation flap surgery, where the incision on the palatal surface. Modified papilla preservation flap is the same procedure where you do the you place the incision on the buccal surface and you reflect the entire papilla on the palatal flap. So it is just a modification, but the original papilla preservation flap has an incision on the palatal surface. Okay. Now, a papilla sparing flap. There could be some cases where you do not want to reflect the papilla only. So in that case, you place an incision on the buccal surface. You just raise the buccal flap. You do not reflect the palatal flap. You do not reflect this the interdental gingiva. So the papilla remains attached to the bone. You don't reflect it only. So when you do this procedure, it is called a papilla sparing flap, where you just spared the papilla. You did not include it in your flap. And here you might give the horizontal straight incision. If you remember from from my previous slides, you give a straight horizontal incision. Okay, I'm just going to show you the video of this. Very easy to understand here. In the papilla preservation flap, a clavicular incision is made on the teeth, mesial and distal to the papilla that is supposed to be preserved. This is a sulcular incision or a clavicular incision. And in the interdental papilla that you wish to save, the incision, instead of splitting the papilla here mid-crestally, you start the incision on the line angle, the distolingual or distopalatal line angle of one tooth, and make a semilunar incision onto the other tooth. And then you reflect the whole papilla on one side of the flap. That is how the papilla preservation flap is done. Okay, so the papilla preservation flap, the incision is made palatally or buccally in modified papilla preservation, and you raise the papilla on one side. But you can do this only if you have a space between the teeth through which the papilla can be reflected on one side. If you don't have enough space, you cannot do this procedure. In those cases, you can go for the papilla sparing incisions. Okay. And the last procedure we'll be seeing today is the distal wedge or the distal molar surgery. This procedure is done on the distal surface of the last tooth because a lot of time there is a pocket on the distal surface of the last tooth. So I'll be showing you the videos for those. There are three ways to do the distal wedge procedure. In one method, you can just, after giving a sulcular incision around the neck of the last tooth, you give another horizontal incision just distal to the last tooth. You raise a flap, you remove the granulation tissue, and then you suture the flap back again. Okay, so this is the easiest way of doing a distal wedge, distal molar procedure. Then another way of doing it is giving two parallel incisions, especially if you have a deep pocket on the distal surface of the teeth, of the tooth. You give two parallel incisions and then you connect the two incisions and you remove the tissue that is in between. You curate the area and whatever procedure has to be done, you do that, and then you suture both these flaps together. This is specially done in case of in the maxillary arch and in case of deep
pockets distal to the last molar. Now, your incision should always rest on attached gingiva, and sometimes you have attached gingiva only on the buccal side or only on the distal side and not on the lingual side, especially in the mandibular molars. So, in the distal to the last mandibular molar, try not to give the incision lingually. Either give one incision distally like that, or you can make a wedge-shaped incision pointing distobuccally. The tissue comes off in a small triangle. You can curate this area and then suture the flap again.
Okay, so that was about the distal molar surgery. So especially if you are an MDS student, because I know there are a couple of MDS students here as well, perio MDS. So if you are an MDS student and you're going to perform flap surgery in your exams, it is important that you incise distal to the last molar as well, and you reflect a flap there as well. And a lot of times, if you have shallow pockets, you, excuse me. If you have a shallow pocket, you can give a single incision. If you have deeper pockets, you may either have to give the triangular incision or the H-shaped incision. If you have good attached gingiva distal to the last molar, you can give an H-shaped incision. But if there is no attached gingiva immediately distal to the molar and you have attached gingiva on the distobuccal aspect, then you can give the triangular wedge-shaped incision. Okay, so that was all about all the procedures we had decided to go through today. And the biggest challenge of gaining mastery in something is to clear our concept. So the best start to any journey of mastery is to clear our concepts, and clarity builds confidence. So the intention of today's presentation was for you to clear your concepts. And if your concepts are clear, you can now start delving into learning more about the procedures. Maybe like study more about it or get a good hands-on on this procedure. So thank you for your patient listening. And I'm really sorry for all the technical glitches that have happened. I don't know why out of all these days today it had to happen. I'm very sorry for all the glitches. I hope I could put my point across, and I hope you all gained something, a thing or two out of this. I am open to questions. If we have any questions, I'm open to address all your questions now. So I see a question. Are there any specific dimensions for the distal incisions? So it depends on the space that you've got. Some patients are going to have nice, good space distal to their molars. Some patients barely have any place. So the dimension is you should just remember that your incisions should rest on attached gingiva and not on movable mucosa. So if your patient has very little attached gingiva, you place your incisions only on that much. So it depends on how much attached gingiva you have. Okay, so that is how you're going to space your incisions. Yeah. So I have another question. Papilla preservation flap is only done when spacing in between teeth. That's correct. So papilla preservation flap can only be done if there is a little gap between the teeth, because if you have space, you're going to be able to pull the papilla from the palatal side to the buccal side. Okay, so it can be done only if you have spacing between the teeth. There are certain modifications of the papilla preservation flap called simplified papilla preservation flap and all, where it's done in places where you have very little space between the teeth, but that is also very technique sensitive. If you don't have space between the teeth and you don't need to reflect the papilla, you can just do a papilla sparing incision. Thank you so much, all of you. And if there were questions when I got logged out, if there are any questions that I've not addressed, you could just put them again because I may not have access. I do not have access to those questions now. Thank you. Thank you so much for this opportunity. Thank you for everyone for being very patient with me today.